Somebody else is doing it.
Can you see my screen?
Yes, we can. Looks great.
All right. And can you see it now in
Full screen.
full
Yeah.
screen? Awesome. That's great. Well, my apologies that I'm not there in person. I was planned to be, but unfortunately could not make travel at the last minute. I want to add my congratulations to Martin. I will have to say that one of the things that I've learned about Martin is that because he is such a pleasure to work with, he is really able to surround himself and make great teams of people. And I think that the KCs are a perfect exemplar of that, because over the years he has led the assemblage of really expert individuals in this. So it's tempting a little bit to say what he said. I will echo many things that Yvonne said. Because this is an organ specific talk, as Yvonne said, you know, we need to focus a little bit on the specificity of the individual organ. And, you know, the immune system is responsible for many things. And as we develop key characteristics, we need to take into account the different functions and how we can mechanistically identify the different functions that the immune system in this case is responsible for. And I just wanted to briefly define immunotoxicity, because we're looking at the characteristics of immunotoxicants. And so these are substances that can alter immune function. And really, when you look at it from a clinical standpoint, we're talking about immune dysregulation. So most commonly we look at immune suppression, but we can also look at non-specific immune stimulation. We can look at hypersensitivity and allergy, and then we can also look at autoimmunity. I wish that I had one of those wonderful pictures of the groupings of the individuals. We did this entire exercise during the pandemic. Maybe one day at an SOT meeting, perhaps we can all gather and have a great picture. But again, just to highlight that, you know, this group of individuals, many are in the room in California, and really a diverse set of folks from all sectors. So you don't need me to belabor this slide. What I really wanted to show you by showing this is that when I look at the cases of carcinogens, what I see are a number of them are associated with what I consider immunologically based events. So oxidative stress, chronic inflammation, immunosuppression. The immune system works through highly coordinated receptor mediated events, and then altering cell proliferation, cell death, or nutrient supply. And when I look at the compounds that are listed in the key characteristics of carcinogens paper, you know, many of the ones that are in there have associations with immune endpoints. So I think this is a critical point. So we have our own little circle, just like the cases of carcinogens. And these are the proposed cases of immunotoxicants. I've starred the ones that are unique, I think, to the immune system. And again, you can see that there are many that overlap with the carcinogens, as well as the hepatotoxicants that Yvonne just showed you. Some of them are associated with particular aspects of immune function, and I'll come back to that in a minute when I get to the clinical slide. And I don't think you want me to read through all of these. I will tell you that this paper has been submitted. Comments were received back in its second round of review now. So fingers crossed, we'll hear good news in the not too distant future. So it's clear that, as Yvonne said, some compounds display multiple cases and produce immunotoxic effects that can either occur in a linear fashion or through multiple independent pathways. We believe that exposure, dose, and duration can affect which KC is most impacted. And so this is, kind of particularly manifested by developmental immunotoxicants, for example, where exposure during either fetal or neonatal development can impact specific functions and or delete lineages that have long-term implications. And they can also affect, depending on the point in life, what specific functions later in life. So we believe that dose and duration are important in terms of the KCs. And similar to the exercise that the hepatotoxicants group performed, we have a couple of case study examples looking at different immunotoxicants. This is showing the prototypical therapeutic cyclosporin, which is used in organ transplantation. And this tends to be a more linear activity. It's known to alter immune cell signaling specifically through the NFAT pathway, and also altering cell death. And that leads to the sequelae that go through other KCs, leading ultimately to very potent immunosuppression. And we all seem to pick our favorite environmental toxicant, TCDD, and did so similar to the hepatotoxicants group. TCDD works through binding to the H receptor, altering immune cell signaling, and really can impact almost all of the other KCs that we identified. And again, distinct outcomes following H receptor activation depend on the ligand, the type of antigen challenge, the immune cell type that's affected, and it can really lead to any of the sequelae that we associate with alterations in immune function. So this is kind of our map of clinical relevance of the KCs. What you can see is KC10 is almost exclusively associated with autoimmunity. KC1 also can lead to autoimmune sequelae, but can also be associated with hypersensitivity. Antigen processing and presentation's also been associated with hypersensitivity. And then the remaining KCs are mostly associated with inflammation, immune suppression, and then non-specific immune stimulation. So just to quickly summarize, we found that the KC approach was applicable to immunotoxicants, and we think we've developed a nice framework for looking at the mechanistic data that can be used in risk assessment and regulatory activities. 5 of them, sometimes I argue that maybe it's 6 if I think about effector function in specific cell types. Some of them are common to multiple target organ tissues, and some of them are very unique to the immune system. Hard for me to imagine antigen processing and presentation, for example, for another set. And then we think that the use of the KCs can improve efforts to identify agents that cause changes in immune function, which may actually help us to understand carcinogens and develop better biomarkers. So for us, the path forward will be to look at the database of known immunotoxicants, potentially look at how the KCs for these known immunotoxicants associate with specific clinical endpoints, such as cancer and infectious disease. And just finally, particularly since I missed the discussion yesterday, implications for risk assessment and regulatory, obviously, potentially help in the design of better drugs, improvement to clinical care and public health, as well as potentially looking at improving the risk-benefit profile of consumer products and therapeutics, and to enhance predictive and mechanistic toxicology. So again, congratulations, Martin. Wish I was there, and thank you for your attention.
Thanks, Dory. Everyone clapped.
Thanks.
It was raucous in here. Okay.